Welcome everyone to today's April PrEP webinar. My name is Dawn Reinhardt-Wood from Rutgers University Department of Psychiatric Rehabilitation and Counseling. And today we're welcoming Dr. Mark Messer, CEO of Terrell State Hospital, and he's going to be presenting on things people don't get about ECT or electroconvulsive therapy. This presentation is sponsored by the New Jersey Department of Health, New Jersey Department of Human Services, and Rutgers Institute for Inpatient Psychiatric Rehabilitation. Next slide, please. So again, we'd like to welcome you and remind you that this is an interactive training and we encourage you to ask questions and participate throughout the session. A recording of this webinar will be made available after the presentation on the Rutgers SPRE website at the link on the screen. And a few disclaimers. The Psychiatric Rehabilitation Educational Program, or PrEP, is an online forum for a variety of topics relevant to state psychiatric hospital staff. While Rutgers and NJDOH and NJDMHAS are co-sponsors of this program, the PrEP webinars are peer-presented, and as such, content is independently developed by the presenters each month. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent. And please note that this session is being recorded for later viewing, so just be mindful of that when using the chat box. So today we get to present Dr. Mark Messer. He is a board-certified psychiatrist who's been practicing psychiatry for 24 years and has been dedicated to the community with extensive experience in public and private inpatient and outpatient settings. These are including, but not limited to, forensic, child and adolescent, clinical research, and presently 3 academic faculty appointments. He's an experienced psychiatric director who continues to actively participate in the treatment of the seriously mentally ill and dually diagnosed patients. Dr. Messer is currently the CEO at Terrell State Hospital, a 305-bed inpatient psychiatric facility in Texas. And for today's learning objectives, we're going to review what type of patient is a good candidate for ECT, what are the contraindications to ECT, and how do each ECT, sorry about that, ECT, ketamine, and TMS differ. And with that, I'd like to turn it over to Dr. Messer.
Before we jump into Dr. Messer, I just want to say that we encourage questions in this webinar today, so please feel free to put any questions that you have in the chat box. And this is such a good hot topic. We want to make sure that we leave space at the end for all the questions to come in. But if you do have questions throughout, please put them in the chat box and we will break in and make sure those get answered. Thank you. Now,
thank you, Don and Jennifer. My name is Dr. Mark Messer, and I'm in a state hospital, one of 10 in the state of Texas, and we are located about 20, 30 minutes just outside of Dallas in a smaller town called Terrell. And we're very fortunate, certainly in regards to this topic, to offer ECT and ketamine and TMS. And besides being the superintendent, I'm able to run the ECT service. Next slide, please. I wanted to start the presentation on ECT, I guess, in a less traditional route. This picture is interesting. Many people seem to confuse this for my high school yearbook picture. I mean, the resemblance is remarkable, although I didn't have 2 big metal electrodes sticking out of my neck. So my introduction is really a brief couple of words about the role of electricity in the medical field. And this particular character, the role that this book played in the development of a number of very key, very important medical devices. Next slide, please. This is the young Mary Shelley, and she happens to be the author of Frankenstein. And what's interesting is that she wrote this book at age 18 on a bet or a challenge with who could come up with the most scary ghost story. But more relevant to the point is that this was the early 1800s. And at that time, current cutting edge medicine involved what was called galvanism. And at that time, it was thought that if you introduced an electrical current into a human, you might be able to bring them back from death to life, resuscitate them. And so the experiments in galvanism involved, for example, getting a fresh corpse, fresh as in just executed by the prison because of a conviction of murder, and by applying electricity through a primitive battery, they might be able to restore life. And this is actually was the thinking in the early 1800s. But what came from this, obviously it was disproven, was the fact that through action potentials that the human body can produce electricity, and certainly the most famous organ in regards to that would be the heart. So it was a little later in the 1800s, the development of the EKG came about with the PQRST wave. And then that brought about the development of a pacemaker. Now we're looking at early 1900s. From there was the development, and certainly primitive at the time, of a defibrillator. So those modes and discoveries of electrical activity in the human body literally saved thousands of lives during, certainly more than that, since their inception. So I don't think people look at the book or the many movies, Frankenstein, as actually having a role in current medicine. Next slide, please. Now, this picture here shows that the fellow in the background, that's actually Dr. Frankenstein. Mary Shelley actually never named the creature in her book. And we're talking about 1817, 1818. The name Frankenstein was more assigned to the creator. And he had robbed graves to assemble this person, put it all together in the proper order. And here we see, as depicted by the movie, the electricity will restore, I say restore life. And hence the famous quote that we all remember from, if not Dr. Frankenstein, certainly Mel Brooks' young Frankenstein. The brain that in his movie they selected from the lab was actually labeled abnormal. And that was kind of the play on Mary Shelley's Frankenstein. Next slide, please. Since ECT's inception, and we're going to talk about that in just a little, it's been very controversial. And certainly the media has portrayed it as a torture or a punishment. And one movie in the mid-70s set back modern psychiatry many, many years and did, in fact, portray ECT as a punishment. And of course, that's the Jack Nicholson movie, One Flew Over the Cuckoo's Nest. But this one tickles me because it says psychiatry's reign of torture continues, when in fact ECT is a very safe, painless induction of a brief controlled seizure of approximately 20 to 30 seconds under anesthesia, which is also very short-lived, approximately 4 to 5 minutes. But we'll go more into that in a little bit. Next slide, please. This is, I guess, a little more on some of the basics. Thoughts that it had caused brain damage when, in fact, non-biased, non-sponsored studies showed that ECT actually promotes neogenesis, where there's actually dendritic growth, which are the little branches or spines off of the dendrite representing neurons in your brain. So it's more neurogenic than neurodegenerative, and there's no known link to brain damage. And the memory loss, I'm going to touch on that as well, my experiences here at this hospital with that issue. Last resort treatment, unfortunately, it is seen as a last resort. Treatment-resistant depression depends on whose definition you're going to use. For the fairly new marketed Spravato, the S-ketamine from Janssen, their definition involves 2 failed trials of appropriate dose and duration as TRD, treatment-resistant depression. Next slide, please. Next slide. Now we can move on to the beginnings of ECT, where these 2 Italian gentlemen actually were the first to use electric current to induce a seizure. During the 30s, there were a lot of medical developments. They were using oil of camphor and other medications to induce seizures, but Cerletti and Benny get credit for the first use of electricity, and tourists can actually go witness or view the bed and location and machine where this very first treatment occurred, which was back in 1938. And ECT really took off from there, because in the 40s and 50s, it was fairly widely used, maybe on into the 60s. But once the quote counterculture came about in the late 60s, where some people were becoming more anti-authority, certainly questioning their parents' values, ECT was seen as was not seen in a positive light. So the use did drop quite a bit. And now if you look at the use of ECT in the United States, this is kind of embarrassing, really. We rank 14th in the country. I'm sorry, 14th in the world for the use of ECT. And it shouldn't be that way. There are certainly other countries where they line them up down the hallway and they may do more than 100 at one center in a day. So the recurring theme in this discussion is that it's a very underutilized, underappreciated procedure that works extremely well. I mentioned the state regulations because Texas happens to be one of the most regulated states in the country. Texas and Colorado are unable to use ECT on any patient younger than the age of 16, which becomes an issue when you're having a patient with severe self-injurious behavior and they're not responding to all the traditional treatments. And perhaps the head banging is so severe, they're detaching their retina. And ECT has shown significant help with conditions like this. So if you lived in Texas and you had a child and you had tried everything and traveled the country, you were left with having to go to a neighboring state like Louisiana, where it wasn't quite so regulated because the government dictated you couldn't do it on anyone under the age of 16. There in the capital of Texas, Austin, there's Scientology, which is a very well-funded group that worked hard to try and get ECT banned in the state, actually in the 90s, 1997. And it's well known their opinion on psychiatry and certainly their opinion on ECT. In terms of the mechanics, let's say procedurally, this is a very simple procedure. Basically, the patient comes to the ECT suite and a IV is placed. That's probably the most difficult or unpleasant part of the whole thing for the patient. Regular IV started in their arm, and they're given two agents. The first one, an induction agent, and we use short-acting barbiturate, methotrexate, which doesn't raise the seizure threshold. And as stated before, it has a short duration of action. And then secondly, they get a paralytic like succinylcholine. And at that point, they don't require intubation. We can bag them for a bit. And once you've pre-oxygenated them, that with a bag, that actually lowers their seizure threshold, blowing off the CO2. You apply a brief electrical stimulus that we measure in millicoulombs. That's a measure of electrical energy. And here we most often stimulate the non-dominant hemisphere, which is the right hemisphere, given that our speech centers in most of the humans on this planet are on their left hemisphere. And so one is placed, one of the leads on the crown of the right side of your head and the other one on the right temple. You're stimulating that hemisphere, and the seizure itself is just nothing but abnormal electrical activity, because our brain, our thoughts are basically electricity and chemicals. And it produces dysregulated, kind of a confused state of electricity that propagates over to the left side. And that's where you would see, without a paralytic, a tonic-clonic-like seizure. And you're looking to have a clinically significant seizure for anything around 20 to 30 seconds. And you're also measuring it by EEG, the electroencephalogram. So that is a short-lived seizure. Should the seizure be prolonged, which is for us pretty rare, it would be easy to break it up by just administering some more benzodiazepine, whatever you had on hand, midazolam, Ativan, anything. You're looking for suppression where the brain has an amazing ability to just put the fire out. You can see it on the EEG strip where you're seeing high amplitude, low frequency waves. And then when suppression occurs, you see this drastic change where you're having a very high frequency, low amplitude. It looks like the very fine tooth blade on a knife. And actually the suppression, which of course is poorly understood, is thought to be one of the theories behind how ECT works. And I think it's important to note the scientific community doesn't give ECT all the credit it deserves because no one really knows how it works. There are certainly several prevailing theories. Don't know exact mechanisms of how it works, just know that it works. Some people simplistically say it reboots the brain in terms of neurochemicals. There's so much we don't know about the brain anyway. So next slide, please. To finish up on the mechanics, as I said, they're very short-acting agents. 4 to 5 minutes, the patient awakens. We take them to the recovery room, and in approximately 15 to 20 minutes, they're fully awake. And we feed them breakfast. They walk back to the ward like nothing happened. The memory issue I sure want to touch on. A lot of the memory-based reports, complaints, data was based on stimulating both hemispheres bitemporal. Each lead is placed on the left and or right temporal or temple. And you certainly see a higher level of short-term memory loss. Here we do a MoCA exam. That's the Montreal Cognitive Assessment for each patient, which does give you a bit of a rating scale in terms of their memory, focus, concentration. We also do a PHQ-9, which focuses on mood. And those are done before every treatment. I have failed to mention the treatment schedule is that it's usually done universally 3 times a week, a Monday, Wednesday, Friday. And it's not just one treatment, it's a course of treatments where the patient might get 4 to 5 weeks. So 12 to 15 treatments total. Usually by treatment number 4, 5, in general, you start to see an improvement. It's not immediate. And if by treatment number 4 or 5, they're starting to improve, then you know that they're going to continue an upward trajectory in their improvement. And as we'll discuss with the patients that are that do well are certainly mood disorders. So with this point indicating major reasons or indications for ECT, certainly depression, be it unipolar, bipolar, certainly for catatonic patients, and there's many, many causes of catatonia. However, mood disorders have a higher incidence of catatonia than psychotic or thought disorders like schizophrenia. But it works extremely well with catatonia. It's also a treatment for NMS, neuroleptic malignant syndrome. It's just not as easily obtainable as Ativan is for catatonia, or things like maybe dantrolene for NMS. The best indicator of success with ECT is actually psychosis. So the ideal patient, this kind of fits the Frankenstein theme. If you were to put together the ideal ECT patient, it would be a somewhat older person with depression and psychosis. That is the ideal ECT patient, and they respond so remarkably well. Age isn't a problem, and then that's where we bring in contraindications, because like an exam question, they would ask, what are the contraindications to ECT? And the answer is actually there are none. But if they put on there for multiple choice, recent MI within 6 months or a space occupying lesion in their brain, those you could say were two contraindications. Certainly you do have to look at their cardiac status. And there might be a patient, if they're fragile, that you might have to get cardiac clearance with. So in terms of safety, statistically, ECT is safer than general anesthesia if you were just really looking for numbers. And if a patient is...
I'm sorry, go ahead, Dr. Messer.
If a patient's to get in trouble with ECT, it's usually going to be a cardiac issue. But we've been so fortunate here, that's not really been a problem. Yes, ma'am.
We do have one question from the chat, and it is, are there characteristics that predict who responds well to ECT compared to non-responders? I think you covered that a little bit, but.
That's a very relevant question, because this type thing is looked at, particularly with ketamine, who might be a responder, who might, or what population might not be a responder. With ECT, that's sure not as clear to my knowledge, who a non-responder. There have been people that have many courses of ECT, many people with over 100 treatments. I'm not sure I can give a good answer to identifying easily a non-responder, but I can say that if they're not responding by treatment number, 9, 10, 11, you do face the possibility they are a late responder, slow responder. But certainly the odds are decreasing. I don't know if that answers that question very well.
Dr. Messer, if you have a slow responder, how long do you let that go before you classify them as a non-responder? So do you see something happening and do you add more treatments if they're a slow responder, more sessions, or how does that work?
I think that if you've gone as many as 12, 13, there's no hard number. But just by experience, if you've gone 12, 13, you're not seeing any clinical response, you're not seeing any subjective response as per the PHQ-9, there's just nothing happening, then first of all, you would move from unilateral lead placement to bitemporal lead placement. That would be a strategy. Are you getting clinically adequate seizures? Is their seizure threshold too high? That would be an issue where you might change the induction agent from a short-acting barbiturate to perhaps something like a non-depolarizing agent like etomidate. But I wouldn't go past 14 or 15 with no results. That would raise flags, red flags, that there's certainly something not right there. And in Texas, you can't give more than 24 treatments in 1 year. And that usually wouldn't be one single course. That would be someone who's requiring a second or third course of ECT. As I said, Texas is very regulated, and you would have to bring in an outside physician to do an evaluation and document it if you wanted to continue on.
Thank you.
That was kind of a long-winded answer to your question. In terms of response rate, I tell patients or their families to look it up in case they're not believing me, but I see numbers. You never want to quote exact. It's always in a range. I see a low of about 70%, and I see a high of as high as 88, 89, 90%. I don't know if that's impressive to everyone. That's remarkably high for any medical treatment. So it's you have to be careful if you're going to quote or cite a response rate. But let's just say it works very well. And here we've been remarkably fortunate. We have a tremendous response rate. And it's important to note they stay on their meds. The medications, antidepressants, still have to shoulder some of the load. And in a strategy manner, you can use ECT as a chance to perhaps change their meds. Obviously, if their meds were working, they wouldn't be in the hospital, whatever regimen they were on. So it affords you some time to start a trial of a different med or combinations. Maybe they're on mood stabilizers as well. Maybe it's a bipolar type depression where they're not even on antidepressants. But that's a whole nother discussion.
We have another question that came in. How do unilateral and bilateral treatments differ in effect and side effects, if any?
Great question. Bilateral is a bit more intense. You're stimulating both hemispheres at the same time. The wave of abnormal electricity doesn't have to spread or propagate quite as far. You're not using typically near as much electrical energy because the leads are sending what is really a pretty small amount of energy, about the amount that approximately it would take to light a household lamp. But it has to cross through the scalp, certainly your skull, and then it has to swim across the spinal fluid, kind of like a moat, and get to the cortex. And with elderly people who have normally age-related cortical atrophy, the electricity has farther to swim to get to the cortex, and it takes more electrical energy. So back to the question, bitemporal is usually quicker, but the side effects in terms of potentially a short-term memory loss that in most all cases returns. I failed to mention the very short-term side effects. Some people get a headache or nausea, which are easily treated with Tylenol or, ondansetron. They respond very well. I hope that answers that question. Anyway,
We
the
had one,
controversy. I'm sorry.
I'm sorry. We have one more question. I don't know if you want to take it now or answer it as you move further
I'll give
into
it a
TMS.
shot.
Okay, what's the difference between ECT and deep cranium stimulation?
Love it. Deep brain stimulation is literally the placement of a very small electrode in the brain with a battery pack of some sort, like a pacemaker, battery pack placed somewhere else in the body. And I don't know about right now, but there weren't that many centers across the country doing deep brain stimulation. I know UT Southwestern in Dallas, Emory in Atlanta, certainly in the northeast, and I'm sure I'm going to be in trouble for not remembering. Maybe Columbia. They were the only centers doing this on an experimental basis. It certainly isn't FDA approved yet, but they couldn't even agree on where to put the electrode. So there was no universality on the appropriate or proper placement of the electrode, but certainly their results were very good. But we're talking about a really obviously invasive procedure, and they were taking people that would volunteer to have it done, and they had to make a big commitment to the center to undergo deep brain stimulation. But I'm sure by now they've refined it, and hopefully at some point they would be ready to present it to the FDA. I don't really know where that stands right now, where they are, or how far it's progressed. But like I say, that's quite invasive versus ECT. And then if you want to get even less invasive, you're looking at TMS, transcranial magnetic stimulation, where you're inducing a magnetic field in a certain part of the brain. DLPFC, dorsolateral prefrontal cortex. Exact placement of the magnetic field is critical. And it's growing, I think, in popularity and success because of new protocols like the SAINT or Stanford protocol, where instead of going every day, every business day, Monday through Friday, for 6 weeks, like you'd see on an outpatient basis, on an inpatient inpatient hospital, you would do it 10 times a day for 5 days. So that's 50 treatments in a week, much more intense versus 30 treatments over 6 weeks. I know I'm jumping ahead a bit, and I don't want to run out of time to discuss ketamine, because that's a fun topic also. Next slide, please. We're here. So ECT, underutilized. People that do ECT are passionate about it because it works so well. It's safe, it's painless. Media portrayal is, any movie you see it in, it's just horrific. So obviously the lay public, the lay press sees it as some kind of torture, punishment, something, just the word shock therapy. So I understand the people's reservation, but if we could get docs to have more patience with that, it certainly outperforms medication. The only, I guess, invasive part's having an IV started. And we just see tremendous success with it. And anybody on this call that does or knows ECT, I don't think would argue with that. The ketamine, very interesting. It was actually created, it's said, in the early 60s in Belgium, but it was introduced in this country in 1969 and was actually used in the Vietnam War for combat soldiers injured in the field. They could get ketamine as a means of controlling their pain. And so over time, it's been used for quite a few things, certainly anesthesia. There are certain parts of the country where if the EMS or EMT service is called by police to help with a highly agitated person in public, they'll give the patient ketamine and that cools them off. We don't see that. I've never seen that here in Texas, but I'm told there are other places that do. But the use of ketamine as an antidepressant, you have to understand it is a very small dose. It's like 0.2 milligrams per kilogram. It's a fraction of of the dose used in anesthesia. And when you look at illicit use, street use, it's just microscopic, because those that are using ketamine as a means of getting high, they're using pretty big dosages. And I guess if your version of a good time is to feel kind of dizzy and dazed and drowsy and wobbly and ataxic, that's the one for you. But Janssen, very famous company, Paul Janssen, the inventor of Haldol, he cleaned it up. Haldol cleaned up was Risperdal, then Invega. But they were very clever because ketamine is a stereoisomer, and they took the S enantiomer of ketamine. That means they're mirror images of each other that you can superimpose. I mean, your hands are mirror images of each other, but you can't superimpose your hands on each other. And I sure don't want to get into a chemistry discussion, but ketamine already had FDA approval back in the late 60s, as I mentioned. For the company to get FDA approval for the indication of depression, and here lately as a reducer of suicidality, it has an indication. They use the S enantiomer, S meaning sinister or left, versus the right or D enantiomer. And that was the clever loophole that allowed them to submit it to the FDA. The point is, you could go to the pharmacy, if you could find a compounding pharmacy and have them make up ketamine for you. And I don't think there's studies showing which one is more effective. Certainly people say that the S enantiomer is more, has a higher affinity for neurons in the brain. Don't know if that's true. My point is, this stuff's amazing in how rapidly it works. And the initial studies were IV ketamine, where they would only administer one treatment, one infusion, and have tremendous results, but then the patient would relapse very quickly. So obviously, a trial or scheduled ketamine became what was necessary, and it's available in many forms. I mentioned IV, there's oral, there's intranasal, which is what the S-ketamine marketed by Janssen is offered in. It's just a mist you breathe into your nasal mucosa. People have different or varying amounts of absorption of the drug, which makes IV ketamine have a little bit advantage. You would know what their blood level is, but that's irrelevant if they're getting better. And I know I'm going to run out of time here.
Dr. Messer, it is 3:46, so I just wanted to give you a heads up on that.
All right, well, just one last little blip.
Okay, you're fine.
Ketamine's listed as an NMDA antagonist, and that's not a very specific description, because there's other NMDA antagonists like dextromethorphan and memantine, amantadine. Those are all very different meds. But here's the one quick thing that's so interesting. They did a study where they took the control group and gave them ketamine. These are depressed patients. In the experimental group, they gave them naltrexone and ketamine. Naltrexone blocks all the opioid receptors, and then gave them the same amount of ketamine. And the results were very clear. Not one person that had gotten the prior administration of naltrexone responded. And all of the no control group did respond. My point is, it's obvious that the model of serotonin, norepinephrine, dopamine, there's certainly more to depression. You blocked the opioid receptors and the ketamine didn't work. I don't know if there's been follow-up studies. Someone on this call may know. I don't, but it's showing us that we don't fully understand the mechanisms in depression. Ketamine works like within an hour in some patients, and antidepressants take weeks to work. And I'll close with that. I'll close with that. Did my screen freeze?
No, you're good. Dr. Messer, we do have an additional question. How about the duration of effect of ECT? So I guess how long do the positive
That's a
outcome?
wonderful question, because ECT, if you get them through the course, whatever it is, 12 to 15 treatments, they have a good response. Hopefully they have remission of all their symptoms, ideally. There is a relapse rate. You don't want to just drop them cold. And if you had to say what the most recent advancement in ECT treatment is, it's that you want to bring them back. Now, we're in a hospital, but we'll discharge them because they're better. You discharge them and you bring them back once or twice a month, more if necessary, more if they're sinking. And you bring them back for 6 months. You start the stopwatch at the time they've responded. And from that point on, you bring them in for little tune-ups once or twice a month for 6 months. And you can potentially, you alter their disease course, and you can improve their prognosis. So obviously the point is the relapse rate is greatly reduced if you can do that maintenance treatment. Hopefully they can get a ride to your hospital. Transportation isn't the limiting factor.
Okay, we do have two additional questions. The first one is ketamine viable as a long-term treatment? I think Dr. Messer may be frozen.
Uh-oh. Hmm. Unless he's thinking really hard about this question.
Quite possibly.
Okay.
Think we should just give about a minute to see if he
Yeah, of course.
didn't fall off. Sorry, folks, sometimes technical difficulties happen. Thanks for being patient.
Bring him back for another one. Okay. Let's see if I just tried to remove him, but then he can't get back in if I do that. So I'm just gonna let it go.
For now, folks, I'm going to go ahead and post the training evaluation link in the chat. So when the training concludes, you can go ahead and fill out the training evaluation. And I'm also going to post a link to the Rutgers IIPR website as well.
And remember, with the training evaluation, you can get a copy of the handouts and also a certificate that you attended today's webinar.
Thank you, Jennifer.
You're welcome. Well, folks, it's 3:56, so I know we have a hard stop at 4 o'clock to be respectful of everyone's leave time from work, and I see that someone said their hospital's having connection issues, so they must be with Dr. Messer in Texas. So thank you all. We're just going to end here, and hopefully we can have Dr. Messer back for more for another round of discussion out of prep sometime in the future. But thank you all so much for being here, and be on the lookout for registration information for next month's prep. It's going to be by Miriam and Allie from Trenton. So we'll get more information on that. And take care, everyone. Thanks for coming.